So now we're going to move on to a debate about when and how and if we should be closing ASDs and if we should have different rules for different ages. And it's my pleasure to introduce Dr. Aboulhosn from UCLA and Dr. Kurt Daniels from OSU. And we'll start with the pro.
All right, great. Luckily, I've already paid off or cajoled many members of the audience, so I will automatically win this. It's going to be like a Russian election here. Or an American one, for that matter. All right, so my point is that atrial septal defects in older patients should be performed with the same criteria as in younger patients. I do have a number of pertinent disclosures, but hopefully they will not affect this talk. So indications for ASD closure. This is going to be in a document that hopefully you'll see soon. You've been thinking you're going to see it for the last year and a half, but what are the indications for closure of an ASD? Well, first you have to start with shunt direction. Is it a left to right shunt? Is it a right to left shunt? If it's a left to right shunt, then you have to do a hemodynamic assessment. And if the pulmonary vascular resistance is low and the pulmonary artery pressure is low, and you have right-sided heart enlargement, and your QP to QS ratio is greater than or equal to 1.5 to 1, and if there's functional impairment, then definitely go ahead and close the ASD, either surgically or transcatheter. Obviously, if you're a hammer, everything looks like a nail, so I would go with the transcatheter closure option in this kind of patient. If the functional impairment is not there, then you can still go ahead and close, given that there is a hemodynamic derangement, and we know that the long-term consequences of not closing an ASD are not good. How about if the pulmonary arterial resistance is high? Well, that's where it gets a little bit tricky and honestly quite controversial. And we can go, and I'm sure we will at some point go into the issues there, but essentially consult with a PAH specialist, consider various therapies, and then consider closure if you have an excellent response. And that's where balloon testing can also be quite important as far as transient occlusion and what happens to the pressures. If you have a right to left shunt at baseline, you have Eisenmenger's type physiology, then you should not close that ASD and you should treat the patient. That's going to be class 3 or harm. Note that in this algorithm, in this flow chart here, there's nothing about age. There's nothing about, oh, if you're over 40, use different criteria. If you're over 65, use different criteria. So I feel like I've already won the debate here, and I could just stop. But I'll keep going. So transcatheter ASD closure, this is the Amplatzer septal occluder. This has been around now for a good 17 years. We all love it. We use it a lot. It's bulky, but it's beautiful in its own way, and it does the job. Let's talk a little bit about hemodynamic changes with age in people who have atrial septal defects. Well, you can see that actually the QP to QS ratio is related to the size of the atrial septal defect, and that the QP to QS ratio does go up with age. As the left side of the heart becomes stiffer, people develop hypertension, diastolic dysfunction, etc. And you can see that the QP-QS ratio is higher in patients with lower pulmonary arterial resistance, and that the QP to QS ratio here is related to LV stiffness. The stiffer your left ventricle, the higher your QP to QS ratio is, which is why someone who may have a QP to QS ratio of, say, 1.5 to 1 when they're 25 years old may have a 2 to 1 ratio when they're 55 years of age. So don't expect that this is a static situation, and if anything, it gets worse with age. How about ASD size and QP to QS ratio? Now, this one's interesting because we tend to say, well, you know, if it's an ASD that's less than a centimeter in size, it's not going to be significant. Well, that's not necessarily the case here. If you look at this and you look at the predicted QP-QS of 2 to 1, or even let's go with 1.5 to 1, because that's what the guidelines are going to use. Well, you can get, and if you take these standard deviations here, you can get a 1.5 to 1 shunt with an ASD that's maybe 5 millimeters or 6 millimeters in size. It doesn't have to be greater than 1 centimeter in size. So the size of the atrial septal defect alone does not completely predict the degree of shunting. What are the long-term effects of transcatheter closure of ASDs on cardiac remodeling and exercise capacity in patients who are older than 40 years of age? Well, let's look at this here and see. This is the RV to LV end diastolic diameter ratio, basically the RV size. What happens to the RV size? Well, at baseline it's large, 1 month smaller, and continues to get smaller over time. So in older patients, you do get good positive cardiac remodeling with ASD closure. That is the reality of it. See, these are 20 ASD patients over age 40, and there was also a reduction in VO2 max in these patients. So this was a patient population that was functionally limited, and they had the TTE and they had the CPET at 12 months. So it's a nicely done Japanese study here showing the positive remodeling that we would want. And then here you look at LV end diastolic diameter. It's not like the LV is just an innocent bystander here. There are some changes in left ventricular size, and you can see that there's mirroring a decrease in RV size, there's an increase in RV size after ASD closure. And that makes a lot of sense because you're essentially putting more blood into the left ventricle when you normalize your QP to QS ratio. And if you have a stiff left ventricle, that can be an issue. You can see a rise in LV diastolic filling pressures. How about RV diameters and RV size? Again, as shown by that graph, you see a nice decrease over time. And how about, and this is important now, how about exercise capacity and some of our measures of functional capacity? Look at the predicted peak O2 uptake here, 53.6 at baseline, goes up to 62. And you see these positive changes across the board here. So certainly there are improvements in this patient population greater than 40 years of age. Here's the predicted peak oxygen uptake over time. The improvement is subtle at the beginning, but over time is much less so. Yet another publication. I mean, I feel bad for you, Kurt, because there's just all kinds of data here supporting my point. Benefits of atrial septal defect closure in adults. Impact of age. So look at what happens here to systolic pulmonary arterial pressure over time with atrial septal defects. And there are other publications that have shown very similar things here, but by the time you reach 60 years of age here, you really start to see an uptick here in systolic pulmonary artery pressure. And a patient with an ASD, by the time they're in their 70s and 80s, is going to have much more pH than when they're younger. So the key is, don't just leave them be here. Close it. Close it at any point that you find it, as long as you can do it safely. And what happens if the ASD is closed as far as RV size here, depending on the age of the patient? How about if they're really old, right? Really old, over 60 years of age?
You just lost some votes.
I just lost a lot of votes. Hold on, I reverse.
Doesn't matter what you say at this point.
Yeah, I know. Are there any young children in the audience? Age greater than 60 here, you see a reduction in RV size as well. Similar to that seen in the younger groups. And systolic pulmonary artery pressure also decreases even in the oldest patient subset. How about symptomatic status? I mean, just to pile on even more data there, Kurt. Functional class improves in every subgroup, including those over age 60 and those aged 40 to 60 years of age. What happens to the left ventricle? How does it adapt after ASD closure? And we do see that there is, and this makes sense, this makes complete sense. This is a left ventricle that's been underfilled for a long time, and all of a sudden you're putting a lot more flow into it. So the BNP here, the NT-proBNP level is going to go up. Your left ventricular diastolic pressure is going to go up. But the good thing about it is it's a transient rise, and then it comes down over time. Your left ventricle will adapt to the volume load. It may need a little help at the beginning. We'll talk a little bit more about that, but initially you may have a problem with that. How about symptomatic atrial arrhythmias and transcatheter closure? Now this is where there's a little bit of an Achilles heel in that you're going to find that there's going to be more arrhythmias in the older subset of patients over 55 years of age. And any of us who do ASD closures will note that in older patients, you're going to have a little bit more atrial fibrillation. Usually it's transient. And it's not something that's permanent. So my conclusions are ASD closure in older patients is feasible and it's safe. ASD closure in older patients results in a decrease in RV size, improved functional status, improved quality of life, Kurt, decreased pulmonary artery pressure, and improved exercise capacity. It's true, arrhythmias are more common in those with ASD closure at a later age, but that is not a reason to deny intervention. The cost to benefit ratio is far in favor of ASD closure. So why, Kurt? Why? Why do you want to deny older patients care? Ageism, I say, ageism. It will not be tolerated.
Thank you, Jamil. I think life begins at 60 and 70, so here we go. So I'm going to take the opposite approach and say that we should not be using the same criteria for older adults as we do for younger patients. And when I think about a debate, I think that you're going to weigh the data, but I also think you're going to be weighing the debaters, the debatees, however it's said. So both Jamil and myself, and most of you know Jamil. So most of you know that when you meet Jamil, one of the first things he always says is he says that I am the Streisand chair, the endowed Streisand chair. He says it, I mean, most of you have met Jamil the first time you meet him. He always, and many times with us as friends, he'll say he likes to be called the Streisand chair, having drinks. And so we have to call him the Streisand chair. And every place you look on the internet, when you see his name, it says the Streisand chair. If you know the Streisand chair, it's Babs, as we like to call her. And Barbara Streisand, a star of screen and stage, a very sexy woman there, and that's so. I wanted to learn a little bit more about why Jamil became the Streisand chair. It's an endowed chair. Most of us who become an endowed chair, it's because of their academics. It's because of their research, education, something they've done well. So I wanted to jump into that so I know who I'm debating and have better understand a little bit about Jamil. And so, I found some old photos, and, back in the 60s, he began to really play this part. And, here they are doing a duet together. And again, at first they were kind of shy about this, but here they are right out in the open, and eventually it just became, well known that so he really worked her hard, and like a Lebanese princess, he worked her.
Is there any other way?
And eventually became the endowed chair. He is the Barbara Streisand endowed chair, so now you know who I'm debating, a little bit more about his background. So I think if I can make two important points, I can win this debate. So follow these two very important points. The first one being that those with PAH and a closed ASD have a poorer prognosis than an open ASD. So if you have pulmonary arterial hypertension, you have an open ASD, your outcomes are better than a closed ASD if you have pulmonary hypertension. So let's go to a paper from the Euro Heart Study, and Dr. Mulder will be speaking in just a moment, the senior author on this paper. And they looked at 1,877 patients. They looked at both open and closed defects. Here's the closed defects in the population. We're talking about ASDs today. And they found that PAH was found in about 12% of those with closed ASD. So even though you closed ASD, 12% of the patient population, this very large study, had pulmonary arterial hypertension. Another way to look at it, here's the populations. They had Eisenmenger syndrome, which was 100% PAH, 33% PAH in the open defects, 12% in the closed defects. And the median age was 15 years higher for those with ASDs who had PAH compared to those without. And so age was a difference in terms of who had pulmonary arterial hypertension when you had a closed atrial septal defect. And the most important part of this study, to make my point, is that if you look at survival data, besides Eisenmenger syndrome, which is down here on the bottom, the next overall worst survival were those with a closed defect with pulmonary arterial hypertension. And there was a significant difference between those and who had an open defect with pulmonary arterial hypertension. So you close the defect, great. The shunt is gone, but you die earlier. Fantastic, right? So there was a significant difference. So to make that point, and I'll make it again in a second, those with PH and a closed ASD have a poor prognosis than those with an open ASD. So you better be sure when you close the ASD that the patient either doesn't have pulmonary arterial hypertension or you think that they're not going to develop it because their survival is not as good. Here's another study from our Italian colleagues in which they looked at patients with pulmonary arterial hypertension in these different subgroups with septal defects and with ASDs. And so we have these different subgroups: Eisenmenger syndrome, PAH with systemic to pulmonary shunts, PAH with small defects, and then PH with closed defects, so PH after a closed defect. And there really wasn't significant differences down through the demographics here, except for a few things I'll mention, which is mostly related to the hemodynamics. Again, if you look at survival curves with this population, you see that this group right here are those with closed defects. So PH with closed defects actually had a worse outcome than the others, even including Eisenmenger syndrome in this particular study. So if you have a closed defect and you have PAH, your outcome overall is worse. And there was a significant difference between, again, PH patients with an open defect versus a closed defect. So again, to make that point. What about PH medications? You may be saying, well, if they're on medicines, you close a defect and they're on medicines, they certainly would do much better, right? If they're on medications in this regard. So if you look back at this study and again, highlight the closed defect patients, you'll see here that these patients were more likely to be on prostanoids and combination therapy. Now, they didn't separate out if you're on medicines, you did better or not, but certainly a large proportion of the patients with closed defects who developed PH and again, did not have a survival advantage were on medication at the time. And what about hemodynamics related to this? And I think this was the important point of looking at this data here that I showed you a minute ago. If you highlight this data from this population, you'll see that the right atrial pressure is higher than all the other subgroups, significantly higher than the other subgroups. And we know the right atrial pressure is the window to the right ventricle, and the right ventricle is what determines really prognosis and health in patients with PAH, and there was a significant difference. There also was a significant difference in pulmonary vascular resistance. Look at the resistance in those with open defects, the second group there, versus closed defects, as you would expect. So again, the hemodynamics are different in this population, saying something about this heart did not handle closure well and did not do well. And again, that would portend the patient's overall potential survival. So point one, those with PH and a closed ASD have a poor prognosis than open ASD. I have to say that that is true. I think we have to all agree that that appears to be true. How about point number two? Point number two is a 30-year-old with an ASD is not the same as a 60-year-old with an ASD. We can now use the same hemodynamic criteria. So I'm going to try to convince you of point number two. So the 30-year-old Jamil, cute guy there, right? Look at him, looks like he's in residency or medical school or something, young, cute guy, is not the same as the 50-year-old, because there's certainly changes that are happening, right? And not the same as the 70-year-old. Look how much bigger his head is getting. He still has his hair, though. Still has his hair. He looks good. He still has his important. Yeah, still has his hair. And Jamil showed this graphic a minute ago about the algorithm when there's really no age criteria. And the question is, should there be age criteria? Are hemodynamics exactly the same in how we should approach patients deciding about closure? So we all know when we heard an excellent lecture about talking about physiology and shunt physiology, shunt magnitude is really determined by the size of the defect and ventricular diastolic compliance. So if you take a patient who has mild pulmonary hypertension in this regard with a mean PA pressure of 28, QBD-QS is 1.5 to 1 would meet criteria, and a PVR it's slightly elevated at 5 units. And maybe this patient, when they exercise, their sats drop a little bit. Is this patient the same as a 30-year-old with these hemodynamics and mild pulmonary arterial hypertension with a 1.5 to 1 shunt, a PVR of 5 units? Is that exactly the same patient as this guy, this 70-year-old guy, this grumpy old man? Is it the same? Is it the same overall physiology? Well, we also have to think about what happens as patients age as well, which is left ventricular diastolic dysfunction. And again, here's elevated left atrial pressure. The QPQS, as Jamil noted, could be high. QPQS could be as high as 2 to 3 to 1 because of decreased compliance on the left side. PVR is low, high left atrial pressure. So this also plays a role as patients age as well. And so when you have a patient that has pulmonary arterial hypertension after ASD closure, what are these predictors? It's very difficult to predict sometimes who these patients will be. So I think this paper that Werner put together in his team really gets to this point about age and how we might look at hemodynamics. And so they looked at their Belgian registry of congenital heart disease patients and pulmonary hypertension patients, and they found 295 patients with atrial septal defects, 273 that were closed, 182 by devices. The mean age of closure was 39. Follow-up was 4.9, and here's some of the follow-up. About 9% had atrial fibrillation, 4% were paced, 8 patients had a stroke, and 8 patients who had died over the follow-up period, 6 of which had pulmonary hypertension. In the latest follow-up, 36 patients had died, 13.3. So again, this number around 10 to 13% seems to keep popping up in terms of those with closed ASDs that have pulmonary hypertension that may have significant issues. So when they looked at the baseline data, the pulmonary hypertension group versus the non-PH group, there was a significant difference related to age. Significant difference related to age in those groups. That's a significant difference. And there's also a difference in pressures, as you would expect. So pulmonary hypertension versus non-pulmonary hypertension, you'd expect the pressures to be elevated or be higher in the PH group. But look at that mean PA pressure of 23. I mean, with the mean PA pressure of 23 and some type of QPQS defect ratio, again, defect size wasn't different. Here's the ratio. You really can't have much elevation in terms of PVR. So these patients, in general, just by average, did not have significant elevations of PVR before their defects were closed. But they are slightly higher, but mean is only 23. At follow-up again, when they followed up the patients, that was baseline follow-up, again, older patients. And percent in sinus rhythm was about half. So again, for survival overall, there was a much difference in survival for patients who had pulmonary hypertension versus not having pulmonary hypertension. So out of these 295 patients, when the defect was closed, over age 55, 34% of them had pulmonary hypertension. If you're less than 55, only 5% had pulmonary hypertension. Tremendous difference. If you're over 55 and your mean PA pressure was over 20, just 20, 75% of them had pulmonary hypertension out of the group. Significant, right? So just a mean PA pressure of 20 made a difference. PH group had a higher rate of atrial fibrillation, right heart failure, and mortality. And here's the difference in survival. You guys would expect the pulmonary hypertension group had worse survival overall. And I think this was the crux of the study, which was important, is right here. And so all the little blue dots are those who had pulmonary hypertension. And we have a line at the bottom, which is age. And line here is the mean PA pressure before closure. So if you drew your line at mean at 25, you can see the number of people that were captured. Again, look how much it's all centered around older patients. But what about if you drew it at 20? How many more people you captured? So if you really drew it at the true number of pH, which is mean at 25, you would have missed all these patients that developed pulmonary hypertension. You would have been off the mark by quite a bit. And if you look at their linear regression analysis, agent repair was the most significant factor for pH likelihood, also mean PA pressure. And so I would say that less likely to develop pH after ASD closure when closed before age 55 and mean PA pressure pre-closure is less than 20. So when I go back to the original statement, the criteria to close ASD, atrial septal defects, is the same for both younger and older adults. Point number 1 is true. We know that pH in a closed defect, they do worse. And also, it looks like the hemodynamics should be different for older folks than younger folks who are trying to decide to close. So I would say we don't use the same. So my last point would be, and we're going to do rebuttals. I'm just going to get mine out of the way because I think I've already won the debate. So I'll do my rebuttal now, and then Jamil's going to finish. Go back to where I started. You've got to learn more about who you're debating, of course, and I'm going to do the work for you. I know you'd want to, if you could, just get on and try to investigate a little more about us, but I'm going to do the work for you. So a little Google review first. There's Jamil, and Jamil's pulling a 3-star. He's pulling a 3-star. And then I decided to go ahead and pull mine up, and all these societies and organizations weighed in. They're all weighing in.
Farmers only.
It's a 5-star, so it's a 5-star. It's a 5-star. Everybody would say. And then I decided to post my dog playing the piano. This is Chloe, my dog playing the piano, and she was able to get a 3.5 star. So. All right, I'll leave that up there as we switch.
So just so you know, 3 stars in Los Angeles is like 10 stars in Ohio. Okay? That's number one. And did I mention I'm the Streisand chair? I don't think I did. Let's mention that again. All right, all fair points. But, we're also, I don't think you give interventionalists enough credit here, We think outside the box sometimes a little bit too. Not all ASDs are the same. And, you don't have to take a 2 centimeter, 3 centimeter ASD and close it completely in one fell swoop, right? You don't need to do that. It's like taking a plane and just crashing it onto the tarmac. No, you can land it more gently. And the way you can land the plane more gently is by actually doing some things like this, which is fenestrating ASDs. Now, Dr. Butts here mentioned balloon occlusion, transient balloon occlusion of defects. I think this is absolutely key to do in older patients. Anybody with atrial fibrillation, anybody with echocardiographic evidence of left ventricular diastolic dysfunction, if they have left atrial enlargement and they have an ASD, you should do this, or at least I do this. Here's an example of us going across the defect with a wire, balloon occluding the defect. This is the wedge pressure with the defect open, okay? This is the wedge pressure with the defect transiently balloon occluded. What do you notice? Well, the wedge pressure shoots up, huge V waves occur. So yes, you will worsen pulmonary hypertension, you will worsen the left atrial pressure if you completely close this defect. The patient may not be extubatable, the patient may need to go on IV diuretics, sometimes even a little milrinone may need to be used. So you don't want to take this kind of patient and just close the ASD completely. You want to think out of the box and do this really sophisticated procedure, which is essentially just take the ASD device, and this is an Amplatzer septal occluder here, and then just gently stab it 4 times. I usually put a picture of Kurt right behind the device. And then you put it in, and this is a 3D echo showing a nice big fenestration here. And this is color Doppler showing that you have a nice left to right shunt. It's not a big shunt, but it's enough to be a pop-off. So you can use this kind of technique, and we use this kind of technique all the time in older patients so that we don't end up leaving them with large defects and then they don't benefit from ASD closure, as I've shown earlier. This is a review of all the studies of fenestrated ASD closure devices. And I'm only highlighting here the ones that have more than one patient and focus specifically on atrial septal defects and have pre and post PA pressures. And what you'll notice across the board here is you actually have a decrease in pulmonary artery pressures. You have an improvement in functional status. People do well with this. And you may say, well, this is just transient, the hole will close over time. Well, there are techniques to keep the hole open. You can actually put a stent inside the Amplatzer septal occluder in order to keep it open and keep that pop-off in place. So yes, it is true that complete ASD closure in some of these patients could potentially be harmful, but we have options. We don't have to just do that. This is just from a series that we published here, just looking at what happened to left atrial pressure pre and post ASD closure if we used fenestrated ASD closure. And lo and behold, you'll see that the majority of patients either didn't have an increase in the left atrial pressure or had a slight decrease in the left atrial pressure. So in my opinion, close these defects, do it judiciously, fenestrate when needed, balloon test, but please don't be an ageist. Don't just ignore people just because they're over 55 years of age. The population is aging and we just have to be fair. Thank you.